Hi everyone, welcome to today's webinar session on guided bone regeneration using regenerative implants. Thank you for taking your time out today and being here. My name is Michelle and I'm your host for this session. I work on a sales team here at Osteopore International where we focus on empowering natural tissue regeneration. We'll first begin with a brief introduction to Osteopore International, and this will be done by Dr. Lim, our Chief Technological Officer, after which followed by the presentation from Prof Wong.
Okay. Hi, Michelle. Thanks for the introduction and a warm welcome to everyone. And once again, thank you for taking time off to attend our webinar. I will start with a brief introduction to the company. And the title of our introduction will be Regenerative Implants with 3D Printed Biomimetic Microarchitecture. Osteopore started out as a medical device manufacturing company from year 2003, and that was after we started research on 3D printing of medical devices in 1996. In the year 2006, we received our FDA 510(k) clearance for craniofacial applications, and we were first awarded the CE mark of conformity in the year 2009. Since then, we have been pioneering 3D printed device applications in various craniofacial anatomical locations, as well as started our expansion into other orthopedic indications. The scientific basis behind our technology is that of tissue engineering and regenerative medicine. I think for those of you who are familiar with this technology, in the lab, what we do is we combine cells, growth factors, and a scaffold in order to engineer tissue. But it has since been close to 20 or 30 years without a lot of successful cases of clinical implementation of tissue engineering and regenerative medicine. I'm happy to say that Osteopore, with our 3D printed scaffold, we have been able to achieve this in the patient by allowing the scaffold to contain bone marrow stem cells, encourage cell infiltration and proliferation, as well as the combination of growth factors in order to achieve what we call a regenerative implant. So the mission of the company is to empower the body to regenerate on its own for tissues that were damaged through trauma, disease, or surgical procedures, with the aim of minimizing or eliminating late complications. For the past 15 years, we have successfully implanted in more than 30,000 cases, and we are at the forefront of regenerative implants when we refer to 3D printing technology. So we utilize the 3D printing technology to create structures that resemble the cancellous bone, and from there, this unique microarchitecture allows stem cells and autologous cells to grow into the scaffold, occupy the space within, and eventually lead to tissue regeneration. The choice of our bioresorbable material is that of polycaprolactone. For those of you, you might be familiar with a suture pack called monocryl. So polycaprolactone exists in monocryl as one of the materials, but our products are made entirely out of polycaprolactone. It degrades in about 18 to 24 months by hydrolysis, and it has a gradual and predictable degradation profile. The degradation byproducts can be metabolized by the citric acid cycle in the body, and recently, a 10-year retrospective publication has also featured some of the potential benefits of using polycaprolactone as a material of construction for scaffolds. As Osteopore, we would like to create advantages for our healthcare stakeholders through the use of 3D printed regenerative implants. We envision this by reducing and minimizing future payments associated with re-surgery or associated long-term care for the payers, such as the government, insurance, and patient. In terms of hospital resource utilization, we aim to focus consumption of resources for new patients instead of having to readmit or conduct revision surgeries for previous complications. Last but not least, for surgeons, we aim to provide a sustainable surgical solution so that patients may return home to their families without long-term concerns. From a regulatory perspective, our company has attained important regulatory approvals in the US, Europe, as well as various countries in Asia Pacific and Southeast Asia. Most recently, the company obtained the TGA approval from the Australian Government Department of Health. In terms of clinical performance for oral maxillofacial and dental applications, one of the long-standing indications has been in the area of orbital floor reconstruction, where the osteomesh is cut to size and placed into the orbit over the defect without the need for sutures or fixation screws. And you can see on a series of CT scans over time that the orbital floor has been reconstructed and the orbital volume has been maintained over a period of 2.5 years. We move on to patient-specific applications in the mandible, and in this case, there is peri-implantitis, where there is bone loss around the implant. We created a customized scaffold that eventually managed to restore the vertical height of the implant, and 6 months on, allowed the patient to have titanium implants and abutments placed in. Last but not least, we have the alveolar ridge preservation procedure, wherein a dental implant is placed into a socket, and 6 months on, we were able to visualize histologically that bone has indeed formed in the socket area. Osteopore wants to improve patients' lives, and we have been aiming to do that and have been doing that since a long time ago. These are some of the news features of our implants in the local news in Singapore, and in this particular feature on the right, it was an extensive 11-hour surgery where the osteomesh was used to reconstruct the face of a Vietnamese patient. So I hope that I've given you a very brief but directed approach to how Osteopore wishes to use our regenerative implants to improve patient lives and enhance clinical care. So I think for the next segment, Prof Raymond Wong shall be taking over to share his experience in using the osteomesh in guided bone regeneration. Thank you.
Now, I would like to introduce today's speaker, Assistant Professor Raymond Wong, Senior Consultant and Head, Discipline of Oral and Maxillofacial Surgery in the National University Centre for Oral Health, Faculty of Dentistry, National University of Singapore. He has had over 10 years of experience researching on various biomaterials as potential bone tissue engineering scaffold for craniofacial reconstruction, especially with respect to the mandibular reconstruction. Prof Wong has pioneered the use of the osteomesh for guided bone regeneration, and today he will be sharing a few cases from his clinical practice and outcomes using regenerative implants as well as surgical protocols. Prof Wong, please.
Hi, I'm going to share screen. Okay, so I've been asked to talk on guided bone regeneration using regenerative implants, and it's standard practice for me to declare conflict of interest. I have no financial interest in any company or company products mentioned. It is not an endorsement, but sharing because I'm a believer. And I'm involved in this area because part of the NUS additive manufacturing cluster, my research is mainly in Trust 4, restorative repair and implants. So I'm going to break out today's lecture or webinar into a few objectives. Number one, why resorbable scaffold? What are the indications and contraindications? And the lessons learned. So it is still early days yet, but I do see very promising results. This is the outline. We'll go through a few methods to build bone and advances in materials and science. Whether this is still experimental and some techniques, and I'm just going to share a few early results. So maxillofacial bone defects can happen as a result of A, extraction, B, trauma causing fractures of the jaws, C, pathology, either benign or malignant, D, a person could be born with it as a cleft, and E, as from an infection. And we do know from guidelines for dental implants that we need a certain minimum thickness of bone in front of the dental implants for stability, for aesthetics reason. This schema shows the options for bone graft, your conventional, your autograft, which comes on the patient's own body. Allograft is another cadaveric, another person or cadaveric. Xenograft is a different animal, different species, sorry. And alloplastic is synthetic. And of course, you can combine it with other novel techniques like your secretomes or cytocrines or growth factors. So when you have bone grafting, there are three possible types of healing. Osteogenic, whereby you have the presence of viable osteoblasts or osteocytes in the graft. So this leads to direct healing. When you have an inorganic material, so osteoconductive. So this is the main technique of healing for most of the bone graft available in the market. So you have an inorganic material that conduct a path for the osteoclast to resorb your hydroxyapatite crystals, and then you get new osteoblasts forming. The third method is osteoinduction. So you have formation of de novo or new bone from the inducement of osteoblasts from osteoprogenitor cells. And the most prominent member of this family is a bone morphogenetic protein, or BMP. So we talk about the types of graft, your autogenous, allogenous, xenogenous, and alloplastic. For the graft to work, the graft cannot move because any micro movements will disrupt angiogenesis. So you need to be able to fixate the graft in place, either you with the tension of the periosteal envelope, or you secure it with some suture or a screw. Then we come to osteoactive agents. You have your osteoinducers, so synthetic recombinant human BMP. This is available, but because it's recombinant human, it's actually very expensive. Osteopromoters, your TGF beta, platelet-derived growth factor, all these growth factors are available in your platelet-rich plasma, or now we call it platelet-rich fibrin. And then, of course, the much newer methods, stem cells and tissue engineering. The sources of graft, your autogenous, whether you take it as a block or particulate, you can take it from the ramus, symphysis, iliac crest, tibia, sometimes cranial bone. And for growing of bone, either vertically or horizontally, you can also opt for distraction osteogenesis. So as you can see in this case here, if you can see my cursor, you have a defect here. And this was after a cyst that has been removed, and there's not enough bone for a dental implant. So what we do is we take graft from the mandibular ramus, bring it up, secure it with screws, pack the surrounding gaps with alloplastic material with a membrane. And then you relieve the envelope and you close. Sinus lift, we all know what we do. You create a bone window, lift the membrane, stuff bone in, stuff the implant in, and close it up. Autogenous cancellous bone graft. This is a slightly atypical case, not mainly for dental implants, but it just serves to illustrate the role. This is an amyloblastoma of about 6 centimeter defect. So what essentially we had to do is to do a segmental jaw resection. That's the segment taken out, fix it with bone plates, take the cancellous marrow together with enrichment with platelet-rich fibrin, and you can see the bone growth that forms, quite good, but it's quite extensive. And we took out the plate 6 months later because the patient didn't like it, and you can see new bone has formed. And that's him 8 months after the procedure, ready for an implant. So when it comes to trying to gain vertical bone height, this case shows severe loss of the alveolus. So you have vertical and horizontal bone loss. And from doing a reverse engineering with the planned prosthesis, the amount of vertical bone height needed was about 1 centimeter. So there was no other choice but to use alveolar distraction. From a 3D printed mandible, we bent the distractor, and after 10 days, the distractor was left in place for 3 months for consolidation. And then, because the bone thickness wasn't enough, he still needed to go for only grafting from the ramus before eventually getting the implants in. So another case also needed vertical bone grafting. You can see severe loss of bone from trauma, and then alveolar distraction and placement of eventually 4 implants. So where I'm coming from is for cases whereby you need a lot of vertical bone augmentation, I think nothing can replace distraction osteogenesis. But for something less, say probably 2, 3, 5 mm, perhaps you could try this method. Now, does anyone have trouble keeping up with advances? Look at all these things that have come out in the past few years. You have your advanced materials, regenerative implants, CAD/CAM, 3D printing, gene splicing, etc., etc. Right. So we have 69% saying yes and 31% saying no. To those who say no, well done. Because I have to admit, I have trouble keeping up with the advances. So all these advances are part of the 4th Industrial Revolution. So in 2016, the World Economic Forum came together and termed all these advances as the 4th IR. So just a brief history. The first industrial revolution was the advent of steam machines in the 18th century. And this led to the rise of the United Kingdom as a world power. Then around the turn of the 19th century, you had the second industrial revolution, electricity and radio. This led to the rise of the United States. The third was digital in the 1990s. You had the tech boom. And then now fourth. So fourth is multiple advancements in all fields. You have biotech, manufacturing, communication, psychology. And I do apologize for this rather busy slide. So I'm going to zoom in on the upper left quadrant. As you can see here, if you look at my cursor, advanced materials. So there are a lot of advancements going on all the time. And then you hear about it and then it disappears from the news. This is what I call Amaras Law. So we tend to overestimate the effect of a technology in the short run. And when the hot news disappears, that's when you get more advances and adoption. So we tend to underestimate the effect in the long run. So tissue engineering has been around for quite a while. And you are slowly seeing more and more adoption. So in healthcare, the 4th industrial revolution, in the field of oral maxillofacial surgery, you have seen things like 3D imaging, 3D planning, surgical navigation, advanced manufacturing, so the patient-specific implants and advanced materials. So instead of just titanium, you have materials that can resorb. So the question then comes to, is polycaprolactone or in combination with tricalcium phosphate, is it still experimental? So if I look through a quick search, TCP is added to improve strength and bone healing, right? At last count, there were 92 papers published in animals and humans. And most of these are approved from the point of view as a medical device, because if you add in biologics, drug-eluting, etc., is considered as a biologics. So it's a pharmaceutical. And this will take 10 to 15 years for approval. So when the tissue engineering first came out, it showed a lot of promise, but it needed a bioreactor, it needed stem cells, material that was strong and non-toxic. So then people ran into ethical issues. The most pluripotent stem cell is your human embryonic stem cells. So to circumvent the issues of ethics, people started looking at this mesenchymal stem cells. So you can take stem cells from fat or from bone marrow. There is a limit though, in terms of size. So you cannot grow an entire mandible, okay? Because there's a limit to the ability of nutrient diffusion by osmosis in the bioreactor, and it is still, after implantation, reliant on capillary diffusion and permeability. So what this means is in larger defects, you still need to implant it temporarily in the host, in the scapula or pectoralis major, to gain vascular supply. And then after a few months, you take it out, harvest it together with the blood supply, and join it to microvascular anastomosis. So yes, there is promise, but it's quite tedious and it doesn't always work. For smaller defects, then you can use regenerative implants, or I call it RI. You can combine it with or without osteoactive agents. But in slightly larger defects, you will find that if you don't add any osteoactive agents, you will have limited bone growth in the center. You will have bone growth and resorption replacement at periphery. We still, though, do not have very large randomized clinical trials. A lot of the reports are, the published papers are case reports and case series, which shows promising results. And all these lead to limited adoption. This was a case done in Germany using this scaffold with PRP and recombinant human BMP to grow bone in a mandible in a single case. This was one of the earliest publications, first in man, showing that this technology works. Then what about on guided bone regeneration? This is a Korean group published not too long ago, showing using 3D printed PCL TCP, but they were all confined to animals. So these were dogs, and it shows that there's very good bone healing. For larger defects, 3D printed reconstruction of a maxillary bone defect, again in dogs. This one, another one. A lot of the early researchers are from Korea, if you notice. And this one is in bigger dogs for mandibular reconstruction. So it shows, the conclusion is 3D printed scaffold showed acceptable potential for oral mandibular reconstruction. Coming a little bit closer to home now, when you have a PCL TCP in monkeys for socket preservation, and it shows decent or very good maintenance of the alveolar contour. There was a randomized clinical trial done in Singapore. This was in 2015, showing that there was better maintenance of ridge height after 6 months as compared to extraction sockets without any scaffolds. But there is a limit to putting it in load-bearing areas. So this is my research group. We were looking at using alloplastic materials as a replacement for vascularized bone. So in all designs, all materials, whether you have endoprosthesis or exoprosthesis, polycaprolactone alone by itself is not strong enough to withstand the forces of mastication. So I will be a bit more circumspect when you reach a defect in the basal bone of the mandible. That's because, especially for the mandible, it is subjected to a lot of forces. You have your sagittal bending, torsion, you have around the symphysis especially, you have your dorsal ventral shear, corporal rotation, and medial convergence. Okay, so currently in human use, the most common use is in orbital floor, cranioplasty. It's been done for many years now, very good results. Socket preservation, relatively new, and guided bone regeneration. Okay, so I'll talk about GBR techniques and early results. What is GBR? Guided bone regeneration is the use of barrier membranes to direct growth of new bone and gingival tissue at sites with insufficient volumes and dimensions of bone and gingiva. I actually gave up on GBR for a while because I found that my results weren't very good. I was using GBR as it was advocated, putting in alloplastic bone or xenographic bone, say bio-os into a defect, relieving the periosteum, putting membranes, and then on re-entry, no matter how long you wait, there is still granular bone. And I mean, you think about it, it's not surprising. You have an inorganic material that you put in, it heals by osteoconduction. Okay, so what happens then is there is resorption of the periphery of the granules, but in the center there's still the inorganic material that is not the patient's native bone. So what happens is if you put implant directly into this bone, it may persist, it may last, but the chances of failure is much higher because you have still tiny foci of inorganic material that is not the patient's bone in contact with the implant. So I wouldn't call it really GBR because GBR is defined as the use of membranes. So the osteo mesh does not replace your collagen membrane. It is meant as a replacement of a bone graft. All right. So what happens is your osteo mesh is polycaprolactone with pores for osteoblast ingress. It becomes sterile. It can be trimmed and bent to fit contour. It is much stiffer than membrane, okay, than your collagen membrane. So which means it keeps its contour and dimensions. So it can, if you want to build horizontal width, it can hold in dimension. Same for vertical bone augmentation. But I would be very careful if I want to go above 3 to 5 mm because you will have reached the limit of the extensibility of the mucosa. So it heals, is printed via fused deposition modeling, right? As mentioned, there's pores for the osteoblast. You can request it as a stock, so it's a straight mesh, or you can actually make it patient specific. It can be printed to fit only the patient's anatomy. Healing is by osteoinduction as mentioned. If you want to jazz up the healing for a bigger defect, you need to add in things like stem cells or consider use of platelet-rich fibrin or recombinant human BMP. The only other alternative for GBR for something that maintains its dimension is your titanium reinforced membrane. The only problem with that is it needs to be removed. Okay, so you need another surgery. It needs to be secured. I mean, you do need another surgery to put implant in anyway, and it may be exposed. The other alternative is to use a titanium mesh. So whether you use a rigid or semi-rigid mesh, or what we call the sugar mesh, it needs to be fixed though. You cannot use sutures. You need to use screws to fix it down, to tack it down. The incidence of exposure, however, in the mouth after putting titanium mesh is relatively high. The only saving grace is that even if on exposure, it does usually quite well because there's a formation of what we call pseudo-periosteum, as espoused by Philip Boyd. It does need to be removed prior to implant placement. And if you ever tried to remove a titanium mesh before with pseudo-periosteum forming below and above the mesh, it is quite difficult to remove. Okay, it takes a while. So this is a case of bone grafting horizontal with placement of a titanium mesh, and after removal, you still see this pseudo-periosteum underneath the mesh, which you need to remove prior to implant placement. So what are the indications for use? It can be used as a bone wide filler, neurosurgical burr holes, craniotomy cuts, augmentation and restoration of bony contour in the craniofacial skeleton. So do not use it in patients with active infections in contaminated surgical areas. It is not indicated for load-bearing anatomical sites, and do not use in areas exposed to the outside environment. So where I'm coming from is, I mean this in cases for sinus leaf bone grafting. Okay, because although you are putting it under the sinus membrane, there may be tiny breaches inside there and you may have infection. Unless you're very certain there is no tear. Okay, I'm going to show a few cases. So consider this case of a lady who has had failing bridge prosthesis. Now you can see there's a broken root at the tooth 1-3. The overbite is very deep. So short of putting a chrome cobalt framework, any dentures there will break. So in the center, you see the panoramic tomogram. All right. So what I've done is I've done tomographic cuts at each area, and you can see for the tooth 1-3, on the labial side there's virtually no bone. The root of the tip of the root is sticking out of bone. So this patient didn't have enough bone for an immediate implant. And if you look at the implant sites for the central incisors and lateral incisors, there were obviously no bone at all. So the plan was to remove the root of tooth 1-3 to build horizontal bone thickness for implant. Then the choice was given whether to use GBR with alloplastic bone graft, as what we conventionally describe, okay, with collagen membrane, block bone graft from ramus or 3D printed scaffold that holds its dimension, combined with a collagen membrane. So standard practice, you raise the flap, take out the tooth as atraumatically as possible, clean the defect of any infected material. If you can, put in some burr holes into the bone to promote bleeding. Then what you can do is you can make a template either with your suture packet. My personal preference is to use bone wax to mold it to the defect size. But when you use bone wax, you must be very careful to remove the wax totally. Otherwise, it will impair healing. So in this case, I elected to put the osteo mesh into two because of the bony stripe in the center. And pardon my bad drawing. This is just a schematic showing the alveolus, the osteo mesh, okay, some particulate bone graft for the extracted tooth root, covered by a membrane. So obviously you can see here the horizontal contour will have changed by a lot. So you need to relieve the periosteum, okay, relieve it until it's passive, adapt the membrane, the collagen membrane over it first, okay, then you take out everything, tack in your osteo mesh, fix it either with a suture to the palatal tissues or with a resorbable bone screw, okay. In this case, I chose to tack the osteo mesh to the palatal tissues with a resorbable suture. Put in your membrane, then tension-free closure until it's watertight. So as you can see here, this is passive. So on stretching of the lip, the incision doesn't gape open. Okay. Another case, failing implant at tooth 1-2. So you can see horizontal bone loss here. In this case, the implant was placed very subcrestally, so the bone followed, and then eventually it failed. You can see there's a radial opacity, radial lucency here around the implant. Okay, so to prevent future problems in restoration and hygiene, I needed to bring to bring the bone level up to roughly about where this orange line is. So in this case, I had to do some vertical as well as horizontal grafting. So on this schema, you can see the alveolus. Okay, so in this case, I needed to make an L-shaped strut. So the membrane is the osteo mesh, I mean, is quite stiff. So you need to be able to adapt it. It takes a bit of practice. If you need to, you can use a hot water bath to bend the osteo mesh to shape. Otherwise, you wet it and with a bit of patience, you can get it to bend. Okay, so same thing. Take it down, put your bone graft, put your membrane, and then relieve the periosteum and tension-free closure. So if you look at the periapical film 6 weeks post-op, because the osteo mesh is not radial opaque at all, you can't see it. But where you can see here, if you look at my cursor, this is where the particulate bone graft was placed. All right. Now, at 6 months post-op, if you look carefully, you can see a shelf of bone here. Okay, so there is bone forming on the vertical aspect, and don't just take my word for it. You can I counter check it with cone beam CT scan. This was taken at 4 months post-op with the implant stand in as a guide. Okay, now if you look carefully, you can see this vertical bone strut here forming, and a bit of bone growth here. Same on the palatal side here as well. So this case, implant was not placed in yet because of COVID-19. We had to postpone any implant surgery. It's still not been lifted yet. Okay, another case, failed implant. Okay, this is on implant 235. You can see a vertical bone ditch here. So the implant was removed, and in this case, I elected to adapt the osteoplug. All right, this was developed for socket preservation. So I adapted the upper half of it, which is wider, clean the infected tissue around the failed implant site, cover it with Coloplug, and then closure. This periapical was taken at 2 months post-op, and this is at 4 months post-op. You do see bone growing. Okay. What are the complications? The mesh, because it's stiff, okay, when you trim the corners, you have to trim off and round off sharp edges. Otherwise, it will poke through the mucosa. And when you are doing, especially in aesthetic areas, the patient needs to wear some prosthesis. So you need to make sure you relieve it totally. Do not place any soft liner that rests on the mucosa, because it will show through, okay, until it has healed totally. So what happens when you get exposure? The saving grace is this implant, this osteo mesh is quite soft in a sense. You can actually trim it to below the contour of the mucosa. So either you use a scalpel or scissors, and it hardly ever gets infected. So the good thing is infection is not a big issue. So once you have trimmed it below the gum contour, it will mucosalize and it will usually heal. So what are the lessons learned from the first few cases placed? There is a definite learning curve. Okay, you do not expect it to be soft and pliable like a collagen membrane. So it is stiff, but because it is stiff, it maintains its dimension. So you won't collapse down. Okay, so you need to wet the mesh, makes it a bit more easy to manipulate. If you have the luxury of a warm water bath, okay, it cannot be above 52 degrees, if I'm not mistaken. Otherwise, you'll melt, right? So just a warm water bath that is just hot enough to touch. Trim and run off the edges, okay, to reduce the incidence of exposure. You must secure it well. If it is exposed, you can trim with scalpel and wait for epithelialization. When you have larger defects, okay, I would advise you to boost the effect with PRF or stem cells harvested from, say, the buccal fat pad or the abdominal fat, or harvested from the iliac bone crest. So, in conclusion, each material and technique has its own place in the armamentarium. Okay, I'm not someone who has a hammer and everything is a nail, but this shows very early promise, and the results are much better than I expected. There are newer advances which might be coming. So you look at the literature, people have looked at using heparin sulfate 3, which is a ligand for BMP. So this improves the healing of bone without having to put anything inside. All right. So my conclusion is there is evidence of early and increased bone formation, and the results so far have been quite good. I thank you for your attention.
We will now open the floor for questions. And a reminder, you can send your questions through the Q&A icon located at the bottom right-hand corner of your screen. So the first question from Charles Xia is, do you recommend securing the mesh, and with what?
Okay, so I recommend that you secure the mesh, otherwise you'll move around. What can you use? You can use a resorbable suture. If you have a resorbable bone screw, it will be fantastic, because then it tacks it into place and doesn't move. If you have a very small defect that the elevation of the periosteum is quite minimal, you can hold it in by just the tension of the periosteum, and therefore you need to be able to suture it quite tightly. Okay.
We have the next question in here. It's by Dale. Dr. Dale, what is the biggest defect you have regenerated?
Okay, can I qualify that question by asking with which technique? Because my biggest defect has been 11 centimeters. But it's a combination of autogenous bone graft, PRF, and bone plates. So with respect to the osteopore product, the biggest defect I've regenerated is probably about 4 centimeters. Yeah, okay, so with the product, that's 4 centimeters.
We have another question in from Dr. Sundin Low. Would you recommend using it on lower posterior with Istovan's sandwich technique and the potential exposure from the thin lingual mucosa?
Well, when you're using a sandwich technique, you could increase the height probably about 3 to 5 millimeter. So you could use that because it is actually no difference from putting in a particulate bone graft. So, so I would think yes, but you need to be able to fixate it. So if you are using a sandwich technique, you will be placing a bone plate there anyway. So I don't see an issue.
We have another question from Dr. Charles Xia.
Do
you have any experience in small segmental resection defects?
Right now, no, because of my concerns about the strength of the product. I mean, even though you will be placing reconstruction bone plates and all this, I'm still quite circumspect of because I do not want any failure in such defects.
Okay, it seems like we have no questions as of now. And it's 4:29. Thank you, everyone. And we appreciate you being here and staying throughout this presentation.
Thank you, everyone, for your attention.